Main symptoms of fungal infections is psoriasis, which is an itchiness, a severe itchiness in the ear. That you can also develop that with a bacterial ear infection, of course, but it's most common with a fungal infection. So I've advised the patient that I'm going to refer them to their GP so they can take an ear swab and get prescribed the appropriate medication. But I'm pretty sure it is fungal. So it is quite a tedious procedure. We're just trying to remove as much debris as we can. A lot of this, as I said, the consistency just makes it hard to suction because it's a very thick, dense, mushy consistency, and that can clog up the suction tube, and it's very hard to vacuum it all off because a lot of it still smears and stains the canal wall and the eardrum. So you are still going to see some debris there, but we've removed quite a significant amount already. They have got some debris at the top of the ear canal and also some in the anterior recess. This patient has got quite a bendy, twisty ear canal, and they've got a prominent anterior recess. So what's the anterior recess? As we approach the eardrum, the ear canal narrows and then it widens again, and it normally widens on the front section of the ear canal, so we call that the anterior canal wall, and at the floor of the ear canal, so we call that the inferior recess of the inferior canal wall. And when the ear canal widens, you get these two recesses, as I mentioned, the inferior recess, so it's like a trench at the bottom of the eardrum, and an anterior recess. It's like a little opening, a cavity, a widening adjacent to the eardrum in the front section of the ear canal. And quite often you can get debris there. With a microscope or an otoscope, commonly you won't be able to visualize inside the anterior recess. So if there is debris there, you're none the wiser. With an endoscope, however, you can see everything. If you hold the endoscope correctly and you get it at the right angle, you can actually visualize inside the anterior recess. So you will see me going back in there. There's a bit of debris there, and it's unbeknown to me at the moment. So I'm just mopping up more at the entrance, and the outer layer of skin in this patient has, in some regions, that region I just removed there, has been breached. The epidermis layer has been broken down because of the infection. So you just have to be really careful because the surface of the ear canal is very sensitive. So I'm going to now try and get into the anterior recess. So I've bent the suction tube ever so slightly. I've got a kink in it, so the kink is moving from right to left, and that enables me to curl around the anterior canal wall. We don't want to make contact with the ear canal to the left. And I'm just getting into that blind spot, and you can see the eardrum moves slightly. So when I was suctioning, the suction power got a hold of the eardrum, so the eardrum got sucked in, and then when I let go, it sucked back out. So it kind of just tells me just to leave that area now. I think there's a bit of debris there. I managed to remove that still, but we've got to be careful because whenever we're working close to the eardrum, we don't want to perforate the eardrum. The eardrum is a lot more resilient than people imagine it would be. That doesn't mean that it's indestructible. It is very fragile, but considering it's 0.2 millimeters roughly in thickness, it's a lot more stubborn and resilient than one would imagine it to be, being only that amount in thickness. So I'm just going to the top part of the ear canal now. So I'm just trying to remove as much debris. The patient was comfortable, and when you've got an infection like this, the more debris you can remove, the better it'll be. Never going to be perfect. We're not going to get rid of that speck. I'm trying to go up into the canal wall. You can see there's still a bit of swelling there in the midsection. The ear canal is a bit swollen.